for our this month's Tea Health Cafe. So as you know that we do every month Tea Health Cafe, and it's a platform for bringing entrepreneurs from medtech, medtech space, medtech healthcare, and also experts, mentor, industry people, so to discuss and understand the challenges everyone is facing. So today we have a very, very interesting topic, which is on connected care and adoption of technology. All the time we talk about technology and whether how it is useful in solving the biggest unmet needs and its adoption in various platforms. So that is what today's discussion's topic going to be. I am Dr. Sonali Khandra. I head the Ojis MedTech Bionest at IIIT Hyderabad. And I have joined by Dr. Sai Praveen, who's a senior consultant pulmonologist and critical care specialist at Apollo Hospital. And he's also a part of the e-access program at Apollo, which is basically, which delivers and provides the tele-ICU services across pan-India. And he's also a member of he's actually in the advisory committee of IIIT as well. So I'm glad that he could spend that time and join today to do this discussion. And another speaker is Dr. Dhruv Joshi, who is a critical care specialist and trained at Cleveland Hospital, and also turned an entrepreneur. So very special guest. He is a part of our earlier cohort and also incubated at Ojis MedTech IIIT and now as well. So thank you so much to both the speakers to provide your insight on this very, very important topic. And with that, I would like to start the discussion. So it will be a 45 minutes of discussion, as already Sai suggested, and then you can always ask your questions. So you keep either writing your questions on the chat box, and then we can take it later, or you can even note it down, and then we'll bring it up. So yeah. So with that, I would like to start the context, which is on the critical care. In fact, I just wanted to share that in the last month also, Dr. Sai, we got 4 different entrepreneurs and talked about on the streaming care and the importance of the remote monitoring of the patients. And it was very interesting discussions. So we got to know their perspectives, that how the technology is adopted, what are the different challenges. And I think now I want to know the other side of the story, the perspective of the hospital per se. So would definitely be very interesting to hear how do you think the adoption of the whole space of the technology in the healthcare and so and so. So yeah, I mean, connected care, we all know, we briefly understand it. What is connected care? I think it's basically to kind of deliver the healthcare services, managing the resources much better way, but and also the whole efficiency in processes and connecting the devices with each other. But we would like to know more about that. What is connected care, how it is useful, and how it is actually adopted in today's situation, before COVID, post COVID, during COVID, how the scenario has been completely changed or going to change in coming years. So with that, I'll start with Dr. Sai. Yeah, I mean, just briefly, can you talk about what is connected care?
Sure. So I think, if you think about Formula One racing, they actually have their cars which are racing around at a really fast speed. Every little bit of data from that car is going to the headquarters, to the pit. And the pit boss is actually looking at that information on the performance of the car. And they are the pioneers in connected care, if you think about it that way. So they actually are looking at hundreds of data points. We are trying to take 20, 30 data points of a human being who is either in a hospital or home in intensive care, and trying to pull that information out and look for trends which suggest if there is anything going on that is abnormal in terms of their vital signs. So that's one way to very kind of simply put what connected care is all about. And the way this is applicable and the way you can think about it is, think of airplanes. I mean, planes are constantly sending data back and forth to the engine is sending information to the captain is sending information to the ground control. So everything's connected and seamless. And if you take healthcare as a parallel to aviation in terms of the safety, the quality, and the 100% accuracy required, so connected care is a way to try to achieve that. So what are we doing now? If you look at the analog world right now, which is where 99.9% of the world still is, you're actually having a nurse or a doctor interacting with each other, with the patient, collecting vital signs manually with an analog device, like say, for example, a pulse oximeter, or perhaps a, like a blood pressure thing, and you're measuring it and checking the blood pressure manually and then writing it down, entering it into an electronic record or manually and looking for trends, maybe plotting graphs. So connected care is where these devices actually send the information automatically, seamlessly, so that you can either manually look at the image and then say, the blood pressure is going up or down, or perhaps you can have a device that is analytic, like doing the analysis automatically, or even now using artificial intelligence to say, this is what the trend is. You can also calculate what are called early warning scores to figure out, is this a patient who's going to decline down the line? Is this somebody with, say, low blood pressure who from infection, is his blood pressure going to improve or not improve? So that's an overview, quick, big picture view of what I think connected care is.
Okay, great. So are you saying it's more like, the hub and spoke kind of method? So you're sitting in one place and you have different branches where you can actually monitor the what's happening in the real time?
Sure, you can be in the same location or you can be far away too. So the remote part of it comes in as a separate entity, but connecting a patient to a device
within the
is that within it can be, you can be anywhere. So it is really the connection part. It's like IoT for humans. So in essentially what you're doing is you're connecting information. And I think Dhruv can add some more light because they've done some really good work in terms of figuring out how to make this very efficient process.
Yeah, I would actually, that brings me to Dhruv as well. So I would like to know your perspective on that, and also why it is so useful. Why do you think it's really changed the entire way the healthcare delivery was provided? Yeah, Dhruv.
So when you think about healthcare delivery, you usually have a few parameters. When you take a big picture view of healthcare delivery, what you want to do is you want to ensure that people have access to healthcare delivery. You want to ensure that people have a good quality healthcare delivery, and you want to ensure that people have a cost-effective healthcare delivery. These are known as the three vertices of the iron triangle, the healthcare iron triangle, right? So now when we actually talk about healthcare delivery as it exists today, unfortunately, it is largely a dysfunctional system, and to a large extent, that is because the need for high quality healthcare by far outstrips the ability for us to deliver it in the analog way, quote unquote analog way, or the old school way, where you have a doctor by your bedside and you have a nurse by your bedside, and they are able to assimilate all of your information, analyze all of your information, put it in the context of what is the right thing for you to do, and ensure that you 100% get the right treatment. That is largely impossible to do in the analog world or the old school way, because there's just too much of data, there's too many data points, there's too much of information, there's too much of evidence, there are so many medications, there's so much of your past medical history, there are interactions between your medications, there are different organ functions of yours that may influence the treatment that you may give. And it is not humanly possible for any one person, be it a doctor or a nurse, to assimilate this and to ensure that every patient gets the access to the quality care that they needed at the time that they needed. And that is why connected healthcare is important, because we're in 2020 right now, and over the last few decades, we have made enormous progresses in terms of technology, be it from processing power, be it from connectivity and availability of bandwidth. And so we need to leverage all of this progress that we have made to be able to provide high quality access to healthcare to all patients. And the only way that it is possible is to have connected devices, right? The only way that it would be possible to do this in an efficient way and ensure optimal healthcare delivery would be with connected devices. There is actually no other way by which you could do this. Coming to the cost effectiveness. So I talked about quality and I talked about access to care. These are two things that obviously connected devices are going to give you, because when you have connected devices, you have access even remotely, even when you're not physically absolutely at the bedside. It gives you access. And also in terms of quality, having the ability of digitized data and analytics on digitized data helps you improve quality as well. So how do we make this cost effective? And that's really been the challenge that technology in healthcare has faced very often. It has been that it is not cost effective. It is too expensive for hospitals to adopt this, or it is too expensive for a patient to pay for this. And we are seeing a change in that respect as well, where technology is getting cheaper, access to bandwidth is getting cheaper, your processing ability of machines is outstripping. I mean, your phone today is the supercomputer of 30 years ago, right? So we're at a place where we need to leverage these advantages to ensure that patients get the care that they need, and that's the importance of connected devices.
Okay, that's so you are basically are saying there's no more silos. People, the devices cannot work on silos. They need to be connected. Yeah.
I think we should keep our ball on the goal. The goal is to ensure optimal patient healthcare delivery, right? A high quality healthcare delivery.
Right.
And if that is the goal, then the only way to achieve that goal would be to ensure that all this humongous amount of data that is coming from the patient or about the patient, or data that you need to put in context of what patient's data there exists, you need to have connected devices. There's no other way that you can actually humanly do that, because humans are great at there are a lot of aspects of healthcare delivery that are human dependent and that need doctors and nurses, and that connected devices cannot replace. Empathy, listening to a patient, talking to a patient, all of these things require a doctor and a nurse to be there, because that is an integral part of healthcare delivery. But there is a lot of other things that are data heavy, that can be done by connected devices and can be done by machines. And we should leverage those machines and complement these two to ensure that the patients at the end of the day get the best healthcare delivery that they can get.
Yeah. So yeah, I mean, that brings to my next question, because you mentioned that's now from 30 years, what phones we have, it's much more, it's like a supercomputer we have in our hand. So there's so much of advancement in the technology. We talk about all the time, technology talks, big data, AI and all that. But you both, in fact, Dr. Sai and you both have good experience on the West and the working in India. So how do you see the challenges for adopting technology per se in India? For that matter, as you rightly said, that the technology is not actually kind of it's to complement, but people have a very a different mindset at sometimes, that maybe they take our job, everything is done by AI, what the human are going to do. So yeah, what is your take, Dr. Sai, on this, how the Indian hospitals are ready to adopt these technologies?
So I think, see, the challenge with India is numbers, because we do have 1 billion people. So there's an estimate of about 70,000 ICU beds, for example, for 5 million admissions per year. Then the other thing is the cost factor. 2.2% of people go below the poverty line every time they get one episode of illness. And hardly anybody that I know, rich or poor, can afford more than 2 weeks of intensive care, whether you have insurance or not. So I think these are the real challenges in terms of who's going to pay for the care, who's going to take care of it. Putting all that aside, the way we practice medicine in India now, as Dhruv mentioned, is a very analog system where you're really looking at very macro points of care and trying to move things along. Fortunately, the human body is very resilient. It is very tolerant to error, and it has its own way of fixing things. So despite many instances where people may be getting the wrong drug, they may be getting a wrong combination of drugs, they may even go undiagnosed, they're able to get away with it because of, I would say, pure luck. But if you really look at it, the human body is pretty complex, and there are many situations where you need to look at all the data to understand what's going on, and that's not being done. The excuse that you don't have time is not there anymore, because your devices can do it for you. your devices can actually analyze information and tell you what is happening to a patient. So the way we take care of patients needs to change. And as a country, India now has the opportunity to leapfrog and avoid all the wasted time in terms of the buildup that was required to get to this point. And we can leapfrog from paper and pen right into an automated system and actually give better care to patients, to more patients at the same time. So if you take a simple example of sepsis is where you have blood infection and your blood pressure drops, and you measure some parameters, say, for example, something like lactic acid. Lactic acid is the same thing that happens when you're running and you get pain in your legs. That's because lactic acid builds up. So lactic acid goes up. So there's good data suggesting that if you can actually give antibiotics early, monitor your lactic acid and see if it's going away, and give the right treatments to a patient with blood infection, you can actually improve their mortality. You can save lives. Now, this data is well known. Likewise, a second example would be patients on a ventilator. Even the corona crisis, people on a ventilator get a condition called ARDS, where the lungs get affected by, they get very stiff. And there's a particular way you have to ventilate the patient with a little low tidal volume, they call it. Even this knowledge is known for 20, 30 years. But the application of this knowledge has not happened. And people are still dying because of that, because people are not following what we already know. And if you allow devices to start automatically analyzing this and adjusting the parameters, we may get better outcomes. So from that standpoint, India has a great opportunity to actually jump and get into the future, actually manage all these patients at a very affordable cost. And I think that is the direction we need to go. The third aspect is a human factor. The Indian doctors have this feeling that there is only a particular way to do stuff. They don't document very much. People really sometimes don't even know what happened to a patient, and that has to change. The way we document information about a patient needs to be altered so that you don't have to do all the writing work, but we need to have a plan as to what happened to the patient and where we're heading next, because critical care of patients requires a detailed evaluation of these people. And that's kind of where I think healthcare is moving towards, where data is becoming information, is becoming evidence, is becoming action.
Great. So what's your take, Dr. Dhruv? You have seen both the side of the story in West and in India. What kind of barriers are there in adoption?
Yeah, no, I think Sai highlighted some of those, and I had mentioned one earlier. Technology has always been associated with the cost, and that's something that has been somewhat of a barrier. But I think nowadays it is more so of an artificial barrier, because the cost of technology, if you look at it in the scheme of things, is actually makes things easier. It makes things better. It improves quality, it improves access, and is actually cost effective as well. What we've always had is one barrier that we've always had is, I think, generally speaking, in the healthcare industry, not just in India, across the world, I would say, is that we have had an inertia against change. And I think I'm a part of the healthcare system, and I think we're all a little guilty of this. We've seen adoption of technology being much quicker across nearly any other industry as compared to the healthcare industry, and a lot of that has to do with our inertia against change, where we've sort of maintained the way of doing things and not necessarily always adopted and changed ourselves and innovated to be current. And that's something that needs to change. I think that change is happening, but it's something that the entire healthcare industry needs to very consciously work on. And I think there's a lot of awareness building that's going on, including forums such as these, which are bringing about that awareness, which will enable some of that change to happen. The other thing that I believe, and having seen, been both lived and worked in the United States, and now been in India for some time, running a healthcare technology company, is that we have very often cut, copy, pasted technology solutions from the West that have not necessarily always been suited for us. Right. So I think it is also imperative that we innovate for our problem specifically, and not assume that any technology that was built for a different setting, a different resource setting, a different setting of people would be applicable to us. And I think in some instances we've been burnt, because some of these technologies are expensive. We think that, since they worked in the US or they worked elsewhere, we're going to put them here and they're going to work very easily, and we invest a lot of money, and that's not always happened. It actually, very often it's not happened. So I think the need of the hour is actually for innovators to innovate for our particular problems. And technology in and of itself is not a solution. Technology as it exists right now is still an enabler. And so we should keep the focus, the problem at the center of our solutions, and not use technology solutions and try to fit them into situations. Rather, we should analyze the situation and make a technology solution for it. And I think that's a challenge that has happened with us, just merely finding some technology that works elsewhere and just try and force fit it into some places. It simply won't work, and we've seen that happen, and that's been a challenge for adoption of technology that we have seen in India. Again, I think that's also changing. I think we've got a lot of really innovative people today working on solving some of the problems that we face here, specific to our settings, and we're going to see some of those efforts bear fruition. So these are some of the challenges that I think we have traditionally faced. The other thing that I would say is that people, I hear this a lot, saying that no, doctors and nurses, technology is not meant for them. um, I don't believe that inherently. I don't believe that inherently, in the sense that Facebook, when it was first created, was meant for college students. It was a college student networking site where people went on and connected with other college students, and etc. Whatever else they did in colleges back then. That was what it was. And Facebook itself, nobody would have said that a 60-year-old or a 70-year-old, Facebook is made for a 60-year-old or a 70-year-old. And so what's happened is that the technology has morphed to itself to be applicable to a 60-year-old person or a 70-year-old person who uses Facebook today. Right. So the 60, 70-year-old person never would have used Facebook at its inception, when it was a college student, rating site for girls and for guys there. Right. But today it does so much more. And that's why it finds its use even among 60 and 70-year-old people. And so I just want to use that analogy, that I believe that it is incumbent on the makers of technology and the technology itself to morph to the users. Right. It is you need, there are doctors and nurses who work a certain way. You need to not force them to use technology. Rather, you need to find out what their problem is and make it easier for them to use what you have to do their job. And if you were to do that, you would see the adoption follow. And we've not really seen that. We still sort of see solutions where we expect people to change 180 degrees and change the entire way they think and the entire way they work to be able to use a technology solution. I think it should be the other way around. I think the technology should change to fit this person's use case and find the solution there. And again, I believe that is what is happening. You have innovators working very specifically on this, finding out what the use cases are, what the problems are, and building technology around those. And connected systems has a huge role to play in this, because everything from how a physician writes a note to how he views his patient's blood pressure or vital signs, whether he has access on his mobile phone or not, all of these things we see those changing, and that's being made possible by connected devices.
So if I might just add a couple points to what Dhruv suggested. So I completely agree that, when innovators are building, and we have talked about this before, Sonali, when we deal with looking at startups, a lot of times they build without talking to the people, the end users. And that is a big problem, because you wasted a lot of your energy and your intelligence in building something that's not going to be used. So I think early on, we started in a hospital an immersion program, and you're aware of this, where we actually invite innovators and startup companies to come spend time with us for a whole week if you want, and then actually look at what we do. And you will often get insights in say, why are you doing it this way? There's such a simpler way to do it. And Dhruv's point about healthcare providers being, reticent to change is very true, but I think it's artificial, because honestly, if you look at it, who would have imagined 5 years ago that WhatsApp will be so prevalent in India? Everybody's using WhatsApp, everybody, and you use it for all kinds of purposes. So from that standpoint, I think it's important to realize that if the technology is designed to be intuitive, easy to use, and practical, it's very easy to actually make it adoptable fairly easily. So I think from those two aspects, I think should be touched on anytime someone's working on a new project.
Yeah, sure. So how the technology comes with ease, that's what is actually going to decide the adoption as well.
Right.
In fact, and based on that, we have the design, and that's what you spoke about with, we are planning to start with Apollo Hospital, that if you want to really understand what is the problem inside, then do a very, very intense immersion program and come out of that, and then start building your prototype, and then start building a product, rather than the technology, and because the technology, you're trying to solve a problem which may not even exist, and then you force on adoption. So that's definitely going to be very difficult part. Yeah,
sure. And I think India, as Dhruv said, let's not copy the West. I mean, there's a whole range of, Africa has a lot of innovators, and India can help Africa. India can help Asia. I mean, there's a lot of stuff that can be done. If it works in India, it's going to work anywhere in the world. So I think that's the idea we should kind of put forward. There's a bunch of questions coming up, I think, Sonali.
Yeah, we'll take them as we have a few more questions, and then we'll definitely take everyone's question. So just want to touch upon the COVID, as we are, as we speak, it's still there. We are still under lockdown. I mean, are not really fully functional. So do you see how there's some changes happen in this time, or going to happen in post-COVID, where there will be a lot of adoptions? How do you see COVID playing a role in the entire barrier of technology? Or if it is so, then what would be the role of this?
Sure. I mean, I could go first. I've already seen, and Dhruv can share his knowledge too about this, because we do critical care for other countries, and we've seen the amazing benefit to having a remote monitoring system, because one, you can take care of patients without getting in their room. Both in India and overseas, we're able to actually control ventilators, guide resuscitation without anybody needing to be inside the room exposed to infectious material. Along with that, the amount of remote care that has started off in March has escalated exponentially. In my own hospital, I think we are ramping up our telemedicine consultations at an extremely rapid pace, even for outpatients. We were able to see patients from all over the place who actually need the care, and they're not able to get to their doctors in their own cities. So that way, I think COVID has created that, really an inroad for telemedicine to come here and stay. I doubt anybody is going to go back from that. 90% of appointments can be done remotely, and intensive care as well as acute care can be done remotely too. So that's the first thing. Second big advantage I think we will be looking at is the innovators are going to figure out how can we get vital signs remotely. I've known several companies out there who have already, in fact, on your phone, you can check your pulse. There's also an app on your phone. You can look at somebody and look at their pulse just by looking at their face. There's a lot of technologies building on looking at other vital signs remotely, including something called optical plethysmography, where you can look at the oxygen saturation, looking at the skin and looking at the pulsations there. So there's all kinds of things coming out where you can do things remotely. There are robots which can be operated remotely. There have been experiments where people have done surgery across continents. So remote care is here to stay. How do we do it safely? We're just building our way towards doing stuff on Mars, for example. If you can do it well on Earth, you can do it on Mars. So that's the kind of direction we're going in, where technology is going to be playing a role in day-to-day care because of COVID. Dhruv, your thoughts?
Yeah, no, I second what Sai is saying. Just being at the helm of a healthcare technology company myself, I can tell you that in the past few months, we have seen developments that we would probably have anticipated in the next couple of years, just in terms of the level of awareness that has been created and the number of use cases where we have been able to help people, help patients. I run a tele-ICU company based out of Bangalore, and we're working with state governments, with hospitals that are, full and running short on people and specialists, and where we have been able to remotely help them and help patients across the country. Also, I think what has happened is I think digital health and connected devices, while inevitable, I would say as inevitable as driverless cars. The it, this the change towards adoption has been accelerated quite significantly with COVID. Like Sai said, a lot of people have not been able to reach their doctors and have found other ways to reach them, and a lot of them are going to find that, hey, you know what, this way is easier than the previous way that I had. And so you're going to see that sort of change taking place. While I have no doubt, post COVID there will be some return to inpatient health that will take place, especially for patients that require in-person consultation and in-person guidance from healthcare professionals. But you will have a large percentage of people that will now use connected devices to access healthcare delivery remotely. And like I said, this was probably inevitable, but has definitely been accelerated by COVID.
Yeah. Great. So, as you said that, I mean, post-COVID things may change a little bit, but my question is, what is the problem with the existing traditional, connected devices? Do you see a real, a gap there, which needs to be really bridged by using future technologies? So what are the present challenges in the connecting devices space?
See, I think if I were to go first, I would say that if it was a really good system, we would be using it already. I mean, we use WhatsApp left and right. We use our phones left and right. If it was a really good system, it would be intuitive and you would be using it already. So clearly there's a barrier to the design thinking in terms of saying, make it seamless. Don't make connected technology one more thing to do. It needs to be part of your workflow. So you need to design it in such a way that it becomes seamless. And this is highly possible. I mean, we're ordering on Swiggy left and right, and the AI is telling you, hey, you ordered parathas last time. Why do you want, whatever this time? So when you can have that kind of thing for food, I mean, why not for healthcare? So I don't think it's hard. It's just that people haven't focused on this in that direction. So if you can give the user, which is the end user, the healthcare provider, and the patient a good experience, you can actually improve adoption. And that, I think, is, in my view, the biggest challenge, because the technology isn't complicated. I mean, you're having RF devices sending data to another device and an engine analyzing the information, and you put in the algorithms that need to do it. See, my watch, I have used my watch, and you can actually look at your heart rhythm on your watch. So I was on a camp somewhere in a rural area, and somebody had an irregular heartbeat. They didn't have an ECG. I put my watch on that patient, and I could see their ECG. And I could transmit it wherever I wanted. I've done it from all kinds of places where you can actually get information from tiny devices. So I don't think it's about the technology part. I feel the technology is evolved far enough. You just need to tweak it a bit. And I think the phone is going to be central to a lot of this. There's obviously miniaturization, newer things coming out, NFC, 5G. All of that's only going to make things easier. I think thinking now has to be on how do we apply what's already out there into the workflow.
Dr. Sai, I would also like to add, I mean, we would like to know the journey of this e-access program which you initiated.
Sure. So just like, Dhruv does tele-ICU, I also do tele-ICU for India. We started about 2013 or so. Our chairman, Dr. Pratap Reddy, for example, he's a kind of visionary, and he wanted us to do remote care for all kinds of, he wanted 1,000 beds connected 5 years ago. It hasn't happened, but we're going, our pace is increasing. What we really do is we started off with hospitals in our region, and then we have expanded to hospitals around the country, and we do remote intensive care monitoring. So essentially critical care, for those who don't know about it, is you have a patient in an ICU where they need to be monitored because their vital signs are abnormal. Pulse is too fast or too slow, blood pressure is too high or too slow, infections out of control, people can't breathe, they're on ventilators, things of that sort. So that's what critical care is all about. And you need really close monitoring of these patients, but there are not enough critical care doctors. So what we do is, just like Dhruv's company does, our company monitors these patients on a 24/7 basis with trained intensivists, and we actually watch their care and direct the care so that things are kind of seamless. The Indian government has made it legal now. Till now, it was, there's no clarity on what exactly, it was never illegal, but there was no clarity. But as of March, it's completely legal to practice telehealth care. In addition to that, we also have in our hospital, for example, the access to the specialists who are not available in remote sites. So one of the sites we are connected to is in the middle of a forest, and anything they need to get is 12 hours away. So for us, we're able to give them a nephrologist, a neurologist. People have strokes, we can direct them and say, give the clot busting drug right now. So our journey has been to slowly ramp up. We cover a lot of public sector hospitals which don't have enough resources. We cover several private hospitals. And internally in the COVID crisis, now we are already monitoring all our COVID patients all the time, 24/7. So we're actually able to monitor their levels of care that are required. Our data is analyzed, so we get alerts if the blood pressure is up or down, oxygen levels are up or down. And I think the journey is going to be to figure out how do we simplify this? Because right now you need a lot of things connected. Can we simplify it in the future with handheld monitors, tinier pieces? So that's the direction things are going.
So this you're talking about in the primary and secondary setup?
So the hospitals are sometimes they don't have anybody other than just one doctor there. And we also monitor places which have complete intensive care setup, but critical care needs 24/7 monitoring of everything that's evidence-based. And the things that save lives are actually not very expensive. Raising the head of the bed to prevent vomiting of acid into your lungs, giving them blood thinners to prevent blood clots, making sure the sugar's under control, giving antibiotics on time. Now, these need to happen to patients every time, all the time. So you can't miss it out. So our system manages to make sure that this is happening for every patient, even if the doctor there is forgetting or not able to do it. Because if you look at the smaller towns, they usually have a mom and pop type setting where the doc and his wife are running the hospital. They live on top. They have a clinic downstairs. They have an ICU attached, and they're monitoring everything, back and forth 24/7. And systems like ours and what Dhruv does help take the little bit of pressure off them, because we can do the monitoring for them and improve their outcomes. And we can actually decrease the length of stay, actually decide if somebody needs to be transferred out or not. And if they need to be transferred, do it in a safe way, because Indian roads aren't great yet. So it takes a long time to transit from one place to the other, and ambulances are not always equipped. So we can actually stabilize a patient in site or make them safe enough to be transported out.
Okay, sure. Sounds great. So Dhruv, how the cloud physician journey started?
Similar. Sai and I have similar backgrounds. We're both pulmonary and critical care specialists who were based in the US before moving back to India. Of course, Sai moved back to Apollo and heralded the e-access program. I moved back as well and started our company called Cloud Physician Healthcare, along with a colleague of mine, Dr. Dilip Raman, who's also an intensivist or a critical care specialist. So in addition to everything that Sai mentioned, which is imperative in the delivery of critical care to ICU patients, because this is what saves lives, what we realized at Cloud Physician was some of the problems that I had highlighted earlier was that we didn't have a technology solution that was made for India for the resource settings that we have here. All of the technology that existed was predominantly made for the US, a few years ago and sort of brought over here. And again, the problems that you have with those technologies is that you bring a technology solution and you're trying to force fit it into a situation where it does not necessarily work the way you want it to. And so we realized that with this problem at hand, it is equally important to develop a technology solution that would address these issues. So to make it easier, to develop mobile applications as opposed to, I'll give you a few examples. So we built Radar. Radar is our technology platform that we use to connect our command center to hospital ICUs, where our team of intensivists are able to oversee the management of these patients in these hospital ICUs. Now, how is Radar different than other solutions out there? A couple of examples. One thing we realized was that Indian doctors and Indian nurses were not very well versed with using desktops or laptops. They were not very well versed with typing out everything that they had. So it was going to be very hard and challenging to give a technology solution to a nurse and have them take a laptop and walk around the hospital ICU and enter data in so that you can remotely access it. That is what was being expected of with the other technology solutions that existed there. And so we realized that, this is not feasible. This is not made for our setting. It is made for the US, where you have every nurse who's walking around with a computer anyway. They walk around with a workstation on wheels going from one hospital room to the other. And so you see all of the modules on that technology solution are made for that user. So we knew that this is not going to work in, a small to medium sized hospital where you're expecting the nurse to do the same thing. It's simply not going to work. And so we had to develop a mobile application that was more user friendly, that addressed the problems of that nurse. Maybe she could not enter in all of the data into the app because she had too many patients to see. So a we built in a module by which the nurse could take an image of the data and use OCR to convert that into digitized format. So these are just a couple of examples. Of course, the functionality of Radar is far, far wider. I mean, it encompasses an entire ICU management suite, which ensures a high quality healthcare delivery to ICU patients. But just these couple of examples that I wanted to give were things that we noticed that the existing technology solutions were not made by people who were immersed in the healthcare delivery in the current setting that we were in India. And so that's why we developed Radar. And now today we're present in over 8 states in India where we're taking care of ICU patients. We have over 300 ICU beds, close to 400 in fact, that are being managed from our command center in Bangalore. So it's been a good journey of building both a clinical team as well as a technology platform to address this problem of shortage of expertise.
Okay, that's great. So local solution for local problem, right? Yeah, you cannot copy paste from what is going on in West. That's very interesting. I think this is what I think all the entrepreneurs should think, that how can they they make technology in a way so that it becomes very easy to use for the end users. So that's what the whole point of discussion. This is what I think that should be the take on. Yeah. So that brings me to the last question. We are also in the very end of this discussion, which is how do you see the evolution of this interoperability standards? How the data exchange happens. What is the evolution happened there? So I'll start with you and then move to Dr. Sai.
Yeah, I think this is, again, like Sai had alluded to earlier, we should take some of the learnings from the West and sidestep some of the problems that they have had. One of the reasons why a lot of the technology solutions out there in the West are very expensive is because of the lack of interoperability. And just making things interoperable adds a huge amount of cost to the solution. And so I think it's imperative that we adopt interoperability standards. We see this happening in the West. And I believe that even industry, and I don't know if there are any folks here from industry, the people that make devices connected with be it monitoring devices or any other devices in healthcare delivery. I think it's important that standards are formed by which everybody conforms to the same standards, so that there exists interoperability and exists ease of data flow between devices, between systems. It may not even be devices, it may just be lab systems and radiology systems, etc. But that's really important. If our goal is to ensure the well-being of our patients, it's really important that we don't create data in silos where it is inaccessible by other systems that may be involved in the healthcare delivery of patients. So it's really important to set these standards in place to ensure interoperability, because that is what is going to help improve patient outcomes. And if that's our goal, that's what we should do. And I hope that industry takes that lead. I hope that regulators take that lead in ensuring that all of us are speaking the same language when we are talking about patient data, so that it is interoperable and easily accessible across platforms.
Sure. I think Dhruv's touched on the most critical aspect of interoperability, and it's all about communication, because there's no point if you can't understand what one device is telling the other. So for example, for my US work, sometimes I have to deal with like 15 different electronic records, and each one has their own quirks. And sometimes the data comes through, sometimes it doesn't. So there's different languages you have to learn to speak about the same thing, which is the patient. Fortunately, patients around the world are, most of them, not the same. They have the same blood pressure, heart rate, oxygen level, and they behave more or less the same way. So there really should be a simpler way to deal with patient data. And I think we are moving in that direction. In a future that I sometimes imagine, maybe we don't need anything other than a smart video camera, which is looking at a patient and gathering all the information. Doctors are talking to the patient, it is gathering the audio and creating its own medical record. The lab data is getting fed into it, and you ultimately have essentially a persona of the patient with all the information generated automatically. Not Star Trek, it's not that far away, but it can actually happen. So I think that's where we are headed very soon. I don't think it's very far away. The human being part of it, the doctor part of it, is still critical to all this, because we need to be able to understand what the machine is saying and why we are doing it. There's a concept called heart rate variability. Heart rate variability is where, if you actually, your phones and your watches might already be measuring it for you, from each beat to beat, there's a little difference in time. It's not exactly the same. And there's a very strong correlation between heart rate variability and mortality. But people have not been able to explain why exactly this is there. So once you start using technology and you start having all these devices talking to each other, and AI kind of gets into the mix, you're going to come up with these inferences which you didn't think of before and can't understand. So one of the barriers and challenges to interoperability is to try to explain what the output means. And it's a very exciting time for healthcare, because you're going to get so much of new information out there, which we didn't even think about before. And it's time for innovators to even think about, how do we help doctors and handhold them to understand how to use these things? Because there's no point having something that does a fabulous job, which the doctor doesn't use. So I think, circling back to where we started, for example, in eAccess, where we run our tele-ICU, one of the main things we do is training. We make sure that we go to the remote site, and the remote site understands what needs to be done, so that they can talk to us in the same language, so that they're able to understand how a patient should be taken care of. So there's a lot of training involved in any of these systems. And at some level, you can get all the information you need to, but at the same time, I think you need to really think about, how can we make sure that the remote site is able to understand what you're saying? So interoperability to me is at a very macro level, in addition to being a machine-based interoperability.
Great. So with that, I'll start those questions. We have already a few questions in the chat box. Yeah.
Sure.
So I'll start with this, the role of Prashant. Yeah, Prashant is asking, role of portable monitoring devices in the healthcare and suggestions of choices.
So there are a lot of portable devices. I think anyone can sort of go and look them up in terms of devices. I will say that, in the past few months, especially with COVID on, there's been a lot of activity in this particular space with portable devices. And you've had a lot of companies, some of them startups, some of them more established companies, that have been not just making portable devices, but also adding additional functionality to them. So I think that question is a really large question, and I think with the if you're specifically looking at devices, I would sort of try to identify the use case before narrowing down on any device as such. What is the use case? Are you looking at it for an inpatient? Are you looking at it for a patient at home? Are you looking at it for an ICU patient? Are you looking at it for a patient in the OT? Are you looking at it for a patient in the ward? What exactly is the use case? And then sort of go into the functionality of the different devices that you have and choose the one that's best suited for you from a usability standpoint, from a cost standpoint, et cetera, et cetera. So I think it's really important to identify the use case in such scenarios, because portable devices is a fairly large space.
Yeah. So with that, I'll go to the second question. That's very interesting, actually. Someone, as we are talking about developing technologies to solve critical problems in healthcare, specifically in India, how one can navigate the incentive mismatch in system to bring technologies to market that really benefit the patient, but are not really revenue boosting for a hospital at large. So how do you balance that?
So that's a very interesting question. It's about, how do you make something cheaper and you're going to lose your profit? There's 7 billion people on the planet and more counting. There's a lot of people who have not had access to care. So I would not honestly worry in the big picture about the need for incentivizing the cost. To me, if we drop the cost of every device out there, there will still be a need for developing intelligent ways of analyzing the data. That whole stream has not been completed. People still need to see a doctor physically. People still need to get procedures done. So healthcare as such still has a lot of stuff that needs to evolve to the point where it's all going to be no profit. I think economies adapt. Economies adapt where even if something gets cheaper, you will develop a service for it. Now, the Apple system, for example, the phones, are not getting that much cheaper, but the phone is now fairly evolved, but they're switching their business over into service delivery. So likewise, I think healthcare itself, even though technology costs might come down, the service delivery piece will continue to add value, I feel.
So they can think of their different business model. They can explore either.
Exactly. And there's still so many things unsolved. I mean, we still have people dying of diseases, which, we still can't do anything about. So if you take, very rare lung diseases, for example, I manage a clinic for a disease called lymphangioliomyomatosis. It's a long word, LAM, it's the short form, where people get holes in their lungs. And the patients of that disease got together and said, there's no treatment for us. So they funded a research trial and found a cure. They found a drug which actually cures that disease. So there are ultimate number of orphan diseases. There's a drug that recently went on sale for I think 5 crores, single dose spinal muscular atrophy, where the treatment works. So there's a lot of stuff that needs to still be done in healthcare. Now, genetics and technology are going to also merge. You're going to start having implantable chips which are analyzing for cancer. So there's a lot of stuff that is still not yet done. The world, there's lots of healthcare is still not done at all. So I would not worry about the economic disincentive of developing technology.
Okay, so we are, okay, so this is from Deepak. We are into developing software applications for healthcare sector based out of Hyderabad. We are looking for hand-holding by hospitals to develop applications which are implemented locally, customized solution to the problem. Okay, so it's not, is it a question?
I think, Sonali, you can directly get in touch with him and guide him. So that sounds like somebody wanting your help. So I'm sure Definitely. They can do that.
You can always, write to me or just MedTech, you can definitely connect. So can you share about any working connect care solution available in the marketplace which can give others like us some indicators of do's and don'ts?
Dhruv, you should take that.
Yeah, could you repeat that question? Sorry, Sonali, I missed that.
Yeah, this is, so I'll read the whole thing. WhatsApp and Facebook is a part of larger ecosystem. Can you share about any walking connect care solution available in the marketplace, which can give others like us some indicators of do's and don'ts? So what is already existing?
Well, I'd love to talk about our solution, Radar. It's out there, it's working, it's helping patients across the country today. We're taking care of, like I said, all close to 400 ICU beds today using Radar. So there are solutions out there. We're not the only one. There are other folks as well who have developed solutions that are out there that are being used. So I, like I said, the solutions are out there, and I would reiterate what Sai mentioned. We're simply scratching the surface. There is so much work to be done in healthcare delivery. We're so far behind, any other comparable industry. So much work to be done on the technology aspect of healthcare delivery that we are going to see more and more solutions coming through. This is just going to be the way of life in healthcare going forward. I have no doubt about that. But they are out there, and like I said, we're not the only people. There are other innovators making great solutions to solve specific use cases in different places. We do it in the ICU space. There are people doing it on the outpatient space. There are so many telemedicine solutions right now. A lot of these solutions are being connected now to portable devices so that there can be real-time data streaming even at home, outside of the hospital. So a lot of work in this space.
Okay, great. So the next question is, okay, is there any platform where the hospitals and technology developers come together and offer a suitable solution to the problem? So I would say yes, Ojis MedTech is one platform
Right.
where, we this is what is our job. We connect, the one side of the story with the other. So if you're
And we've had a bunch of hackathons, haven't we, Sonali? So these
yeah.
hackathons are a good place to connect and get your idea kind of, fast track to figure out, which direction to go. And I think I'm sure Dhruv's been part of it. I've been part of several where we mentor people and guide people in terms of where you should go next. And I think the key element, the takeaway for you should be, don't restrict your ideas, but talk to a healthcare system provider to say, okay, am I on the right track? Even better, go into a hospital system and spend time and understand what needs. Simple thing, personal protective equipment is still so cumbersome. When you wear it, you're fairly breathless. You can't see, things fog up. We don't have a solution yet. There's no great solution yet where you can just have a very simple personal protective equipment where I don't have to wear all the cumbersome stuff. No one's developed that yet. So somebody out there is inspired to do it. I'll be buying it from you very soon if you can build it. The personal protective equipment when you're seeing corona patients, for example.
Yeah. So this is specifically for you, Dr. Sai. Vijay Gopal, he mentioned that we are working on video analytics-based multimodal diagnostics, and what you just mentioned is very much in a line. And they would love to connect and
absolutely. I've already emailed, given him my email. He can get in touch. That will be great. Sure.
Yeah. Okay. Yeah. Can bionic chips implementation play a significant role in creating user-friendly solutions? So this is from Sachi. Yeah.
Yeah, I mean, see, do we want to take that? You want me to take it?
Go for it, Sai.
So if you look at exhale breath analysis, so there are technologies out there where you can analyze various organic chemicals, volatile organics coming out in your breath, and you can actually figure out cancer and many other diseases. And that's a very field that's not yet very nascent, and people have not gone very far ahead in it yet. So that's a field where you could use that. An implanted chip in you, which is analyzing your blood sugar or your lactic acid or anything else, or looking for cancer cells or looking for coronavirus. I mean, these are not in the future. They're already out there. If you go to a website called clinicaltrials.gov and type in any word you want, you're going to come up with a whole bunch of research trials on anything you want. If you go to pubmed.gov, type in any word you want, you're going to come up with a whole bunch of research that's going on. And most people are looking for collaboration. So a lot of investigators don't have access to the kind of clinical material we have in India. They don't have access to the kind of smart guys like yourself and smart men and women like yourselves who actually are able to do stuff and move their project forward. So in this time where geography is history, where geography is no boundary to actually doing what you want to do, you should really seek out collaboration with any place that you want, and you should be able to go ahead and get these things done.
Yeah. There's another question from Sachi: is omics-based technology adaptable to healthcare specialists? Are there enough adaptation for omics-based technology?
Right, the same thing. So, for example, the analytics for cancers. So, in our hospital, for example, we have a couple of people working on looking at blood-based diagnostics for brain cancer. So, those are already going on. So it's already happening. There's many people doing these things, and there are many companies who have been built around the world just based on this technology.
Okay, there is another thing which is basically what we talk about, the intensive clinical immersion program, which we are actually planning to do with Apollo Hospital. So I think this is more like a recommendation or observation from Prashant. He's talking about what's the journey in the next 5 years you see in the digital technology is going to take over. So do you think that each team should travel with doctors in hospitals and clinics or the surgical theaters and come up with the tech solution which solve the problem and enhance the doctors work and also help patient in engaging for remote and telemedicine practices?
I'll have Dhruv comment on that and I'll answer.
know, they learn.
Yeah. I think, see, obviously starting early is going to make a difference, but we sometimes need a kick on our backside like Corona did, where everybody's got to evolve. And this is the kind of positive change that's going to happen because of that. Because I think, just going to say, I'll answer both the final comment and this question where we are more inclusive. So I have a quotation that I use in some of my slides. I'm going to read it out. Technology must transform healthcare through cutting edge science combined with compassion, creativity, and cost effectiveness. Innovation must be integrative, inspiring, imaginative, inclusive, and instructive. I'll type it out sometime. But essentially, I think if you can actually figure out a way, keep the basis of your entire project as I want to help that population, you will work backwards and make it work. The science will find itself, the research will find itself, the people who need to help you will find themselves and help you. So I'm a firm believer that if you keep the outcome in mind, and it's a fairly, it's an altruistic outcome, you want to say, I want to fix this problem, you will always find a solution. If you look at the greatest inventions that have been done, they didn't start with somebody saying together, I'm going to put a battery and cells together. It was more like, how do I fix that problem? And they work backwards. So that's generally what happens.
Right. So address the problem, which is really unmet, need. So don't rush towards the finalizing the technology, find out the problem, and then choose your technology accordingly.
Correct.
So do we have a poll, Sai?
We'll be taking that over the feedback mail, Sonali.
Okay, fine.
We are already 10 minutes late, and request audience, if you can quickly switch on your video, we'll take a quick snap and end the session.
Yeah. So while everyone is coming online, I just wanted to also announce one more thing, that please keep writing to us to get such kind of insights, so we would also know that what exactly you're looking for. So we would be really loving those suggestions as well. So yeah.
Many of them are it looks like they're camera shy. That's okay.
So thank you so much, Dr. Sai and Dhruv, for giving your time, and thank you so much for all the participants who have joined this Monday at 6 o'clock. And we'll be following up with programs and the contacts of both Dr. Sai and Dhruv. If you have any queries, you can post them to their emails. Thank you so much.
Thank you, Dr. Sai.
Thank you. Take care. Thanks, Dhruv. Take care. See you. Bye.